Hi, everybody. Welcome to this webinar. We're so grateful that you joined us. My name is Dr. Collins Harrell. I'm a general dentist in Southern California. I do a lot of orthodontics. I trained back in 2006 with Progressive Orthodontic Seminars. I treat a lot of orthodontic cases with both brackets and aligners. I'm currently full-time with Progressive Orthodontic Seminars as the clinical director and head instructor. And have the opportunity to teach doctors around the world how to do great ortho in their practices. So grateful that you would join us. I'm very excited to introduce you to a new app that's available in the Medit link app store for you to download and use, and would love to introduce you to that app and hopefully show you the value that this app can add to your practice. We have a lot of different doctors joining us. We have some doctors who are general dentists who just have never done ortho. We have general dentists who have done or do a little bit of orthodontics, limited aligners. We have some general dentists who do both brackets and aligners and treat a lot of cases. We have some orthodontic specialists joining us. We're grateful for that. And even some pediatric specialists and prosthodontists and periodontists. And so we're welcoming all of you and think that you'll have fun learning about this app and seeing how it can add value to your practice. So let me go ahead and show you where to find this app. Share my screen with you. All right, so here we have Medit link. And where you find this app in Medit link, so from the dashboard, there's over on the side, there's an app box. So if we go into the app box, you'll be able to find the new Progressive Orthodontics app. Go ahead and download that and get it installed. And once that's installed, let's go back to a patient here. This is not a case that I treated. This is one of our doctors in Australia, Dr. Lucy Galletley, who works with our founder, Don McGann, and they work together on this case. He was a mentor for her on this case, and I'm grateful that she shared this with us. So let me show you how the app works on this case. What I've done already is we've uploaded the STL files. So we already have created a case or a patient. And if you scan with a Medit scanner, you're going to scan a nice colorful .ply scan right into Medit link. If you're using another scanner, you can export from another scanner and then import by using this little attach feature right here. So obviously you have to have an STL file or a .ply file. You have to have an intraoral scan to be able to use this app. And then you can attach other things to use in the software as well. So you definitely, if you have one, will want to attach a lateral ceph. There's functionality that we'll talk about later that is available when you have a lateral ceph attached. So if I have any photos, here you can see we have some ortho photos. This particular patient is missing an upper left lateral incisor. So if you want to attach photos to refer to while you're treating or working up the case, you can also attach those here so that they become part of the patient or case file. And then all of those things will be available when you're working up the case. So we at least have the STL file. We can go ahead and click the icon to open the Progressive Orthodontic app. So let's get that opened up. I've already worked up the case, but let's cancel that and do it brand new. Okay, so here's where we assign the data for this case. So I can drag and drop the mandible and the maxilla. Another way you can do it is click on the image here and then click on the arrow and say that ceph goes here. And then I'm just going to go ahead and put my other images in so that we can look at them while we're working up this case together. Now, this software was designed for you to be able to quickly and easily work up these cases. Somebody who's trained on the software can work this up in about 3 to 5 minutes. It's very easy to do. And the idea here is to keep it simple so that you can train a staff member, a hygienist, an assistant, to scan the patient and very quickly work up to a point where you have an orthodontic simulation created, and you can display those side by side. So you have the patient's original scan data sitting next to the patient's straightened teeth. And that starts conversation before the doctor even ever comes into the operatory for the exam. I promise you, I don't know how you're using your intraoral scanner right now. You know, a lot of us as general dentists only use the intraoral scanner when we're cutting crown preps or bridges or doing implants or any type of restoration. We're using it as a digital replacement for polyvinyl impression material. And it is amazing for that. It's a great use of that tool. Some of you are probably using your intraoral scanner also if you're doing aligners, which is a great use because aligners definitely fit better and you definitely get better aligner treatment if you used a scanner, especially if it was a clean scan and you got all the plaque and calculus off the teeth and did a great job with the scan, and treat that scan almost like it's a scan for a restoration so that you can get intimately fitting aligners. But a lot of you may not be using your intraoral scanner as a tool for diagnosis and for treatment planning and educating the patient and having conversations that will lead to more comprehensive dentistry. And I know that that's the type of dentistry that we all want to be doing. You know, we'd all love to be doing more and better dentistry, higher level dentistry, more comprehensive dentistry on fewer patients. And so I promise you, if you will scan all of your patients that come into your practice, use your intraoral scanner, get another intraoral scanner, have one that can be used plug and play, you know, one of the wonderful Medit plug and play, take it into an operatory and plug it in and scan the patient. And so every patient that comes in is a new patient. Every returning patient that comes in for a hygiene appointment is getting a scan of their mouth in addition to taking x-rays. And that way, when the doctor comes in, you have this beautiful three-dimensional color image up on the screen. The patient's already started talking to the assistant or the hygienist about the conditions that they can see, curious about what they're seeing. They'll end up talking to you about, you know, things that you maybe wouldn't even have treatment planned, but they see it and they want to talk about it. And so now you end up replacing some old broken restorations or maybe just discolored restorations. But the minute they see those straight teeth next to the crooked teeth, and the conversations about, hey, have you ever thought about straightening your teeth, is always going to lead into cosmetic work, into more comprehensive dentistry. And that's why I really love this tool. And I really love this app to be able to do this on all of our patients. And then it also documents the starting condition of the mouth. It gives us the ability to track changes over time. There's a lot of power and value in taking the time to do an intraoral scan, a full mouth intraoral scan on every one of your patients when they first come in, and then when they come back for recalls, maybe once a year, just to keep track of how things are changing over time. So let's go ahead and look at this app. We've opened it up. We're on this first screen here, which is just a screen to do any trimming of unnecessary data. We find if you have lip or tongue or a bunch of unnecessary data in here, that can sometimes throw off the simulation. So if you have anything that's not necessary, it's very easy in here to just trim that data off and get rid of it. Okay, but not a lot to do in this screen. If you have a hole, you can fill holes in this screen, but not really a lot to do here. So usually you just click on through to the next screen where an occlusal table, a functional occlusal table, is positioned onto the arch form. Okay, so we're using the distal buccal cusp tips of lower first molars and the buccal cusp tips of lower first bicuspids to establish this occlusal plane. Now, sometimes the software doesn't automatically find these teeth, or those teeth are missing, or I don't like the way it placed it. So I have a little tool down here that's called a detached data tool. If I click that, I can just go and place those points myself again. Now, if one of these teeth is missing, I would still find symmetrical points. So if I was missing one of the molars, I might put it on the mesial buccal cusp tips of the lower second molars, and then also on those cusp tips of the first bicuspids. We just want 4 symmetrical points to establish an occlusal plane to which the teeth will be aligned to in a vertical dimension. So super easy, usually does it all by itself. You just click onto the next page. This page can be a page where either everything's perfect, or you might spend a little bit of time having to designate the segmentation and the numbering of the teeth. Okay, so I find that a Medit scan does a really nice job of identifying the data and actually identifying the teeth properly. And depending on how clean the scan is and how well defined the patient's teeth are, this page can take very little effort, or it can take a little bit more effort. I definitely want to encourage you to use a mouse. It's hard to do with a trackpad. And so with a mouse, you have a right click and a left click, and sometimes it's a double click. So any feature that you want, usually it's available with a right click or a left click or a double click or the scroll. Okay, so at first this took me a minute to learn how to use this tool, but just like everything, there's a learning curve. And once you learn how to use it and what you're doing, it goes very quickly when you need to make adjustments here. This case you can see came in really nicely. The only problem is that the tooth numbering is wrong. So it shows that this central incisor is a lateral incisor. Okay, we have the numbering here for the international quadrant 1, quadrant 2, quadrant 3, quadrant 4, and each tooth is numbered 1 through 8 in that quadrant. So that should be a central incisor. See, it shows over here that that tooth is missing. So I need to rearrange these teeth. Everything seems to have painted well and been segmented well here, but I need to renumber these teeth. So I'm gonna go take this tooth and click on that and say that tooth is 2-1. And then it says, oh, then we're missing the 2-2, okay? But if there was a tooth that wasn't well designated, say this one here, I can quickly go in and erase everything, and it defaults over to this smart tooth selection tool, and I can just double click on that tooth and it will re-identify the tooth, and I can confirm that. Okay, so sometimes there's a little bit of work to do on this page. Sometimes it's real easy, like what you saw here. Now in this case, I'm gonna click, it's a left click on that grayed out tooth, and it tells me that I have an option of saying that it's an unerupted tooth or that I plan to restore that tooth, a planned prosthesis. If I click planned prosthesis, it's going to put a tooth there. It's going to move the teeth in the simulation and put a tooth there so that I can see what needs to be done to restore this, or what it would look like if I was to restore this with a new lateral incisor. It's going to take that lateral incisor from the other side. So if there's a contralateral tooth present, it's going to copy that tooth and it's going to duplicate it and flip it over and put it on the other side. If they're both missing and we designate both of them as planned restorations, then it pulls it from a tooth library. Okay. So that's what happens in this. There's a lot of other things that we can do in this screen with a planned prosthesis, with planned extractions, partially erupted teeth, missing teeth. But for this case, the simplicity is just saying, let's plan to put a restoration there where it's missing. That's why this patient came in. Here, I'll show you the pictures. Okay, so here you can see that this patient is missing, has a big gap between her front teeth because she's missing a lateral. And so because of that, her central incisor is drifted and her canine has drifted. And so we have to move things back into their original position so we can put a tooth there. Okay. So here's what the original panoramic x-ray looks like. You can see that we're going to have to control those roots when we try to open up the space if we're going to put an implant there. And so as we look at the orthodontics involved, we might even use this to help us decide whether we want to use brackets or aligners or brackets and aligners. But that's what we've got in this particular case. So we'll move on to the next step. These have been properly identified. We've said that we want to put a restoration there. And then if we've uploaded the lateral ceph, it's going to automatically trace that. And it's a simplified ceph tracing just for simplicity so that we can quickly go through these screens and not spend a lot of time. The software is not over-programmed. It's just giving us enough data to kind of know what we're dealing with here. So there's some key points that are placed. There's Nathion, B point, A point, condylion, upper and lower molars where they occlude with the occlusal surfaces, and then the tip of the upper and lower incisors. Now, these are the points that are being used and that can affect the simulations. If I don't like the way those points are placed, I can click on the edit tool. All of the little green dots allow me to adjust the tracing if I want to make the tracing look different than it looks, but those don't affect the simulations. They're just to make it look nice. The red points, however, if I don't agree with the way that the software identified those and placed them, like that incisor tip is definitely up a little higher, so I can move that up. Or if I don't agree with the way it placed these molars, I can move those up or down. Okay. But once I'm happy with that, it's going to go ahead and move on and show me a superimposition of my three-dimensional model onto this two-dimensional image. And this will be used later as we look at different simulations to see how much advancement or retraction the particular simulation that we're looking at would produce compared to the original. Sometimes it doesn't place it perfectly. I can either kind of adjust it manually, But if it's not calibrated right, I can detach this data and I can recalibrate that by finding a point on the front and the back of the model that I can clearly see in the X-ray. So I can clearly see where the tip of that upper incisor is. So I can put that red point on both of those spots. And then this green point in the back, I can see where that distal marginal ridge is. So now it's well calibrated and positioned. And you can see that there's some traffic lights here. There's green coming out, okay? And if I look at where I'm at on the scale, with the widths measurement, I'm at negative 2.001. And so you can see at -2, I'm right on the cusp of where this should turn yellow. Okay, so if I'd place those points just a tiny bit differently, this would be giving me a little yellow flag saying that there's a little bit of a skeletal class 3 component to this patient. Okay, meaning the mandible's a little bit forward compared to the upper jaw. So I may be dealing with a little bit of a lack of overjet or a little bit of class 3. In the vertical dimension, we're getting a green at 26.6. That's right here in the middle. So in a vertical dimension, this patient doesn't have any real severe problems that we need to be aware of, discrepancies or imbalances. But in the anterior posterior, she's a little bit of a class 3 skeletal. So if I'm looking for easy cases to treat, I use this traffic light system to help me with case selection and go, hey, I'm looking for the green, or maybe the green that's the yellows that were almost green and they're just barely yellow. But if it's solid yellow or red, or the yellow close to being a red, and I don't have a lot of experience and understand what I'm doing, those are better cases to refer to a specialist or work with a mentor or somebody who can help you, because there may be some unseen, some hidden complexity that might end up being a problem or a surprise to you. So I really like this little traffic light system. As you go through, you'll see that we use traffic lights at different points along the way to show case complexity. It really helps with quick case selection. On this next screen, our purpose here is to identify the original shape of the arch, because one of our simulations is going to be to maintain the original arch form. We will have options to expand that arch form, but here on this screen, we just want to identify the original arch form. So it defaults to a medium ovoid. We have a series of different arch forms to choose from here. But medium ovoid seems to fit a large majority of cases, so it's a good starting point. If I was to say small ovoid, you can see that that is a little bit constricted. This would definitely cause constriction in the posterior, which would cause more advancement in the anterior as we align the teeth. And if I went with a non-extract ovoid 2, which is a more expanded arch form, you can see that this would cause expansion in that lower arch. And so you'd have less advancement, maybe even a little bit of retraction, especially if I went up to the upper and said non-extract ovoid 1. You can see that that would create a lot of upper expansion. And maybe we need that to create the space here, but not really sure. So let's go ahead and choose the medium ovoid, because that is the arch form to maintain. And then we'll just kind of position it so it looks centered from left to right. So I'm looking at the way that it overlaps the posterior teeth and just kind of making it centered from left to right in both upper and lower, so that it's symmetrical. Now this little blue line doesn't really do anything. It's just there if we want to look at the dental symmetry. So sometimes there's dental asymmetry in an arch. You might have a molar that's real far forward on one side and further back on the other side. Maybe a primary tooth was lost early, things drifted. Maybe we lost a tooth on one side. Like you can see over here on the upper, since we're missing a tooth, you can see that this molar has drifted more mesially. When I compare the position of these two bicuspids, these have definitely drifted more mesial. So there's some asymmetry in this upper arch form because of the missing tooth. And that central incisor has drifted distally, but everything else has drifted mesially. So it's just there to help us evaluate the symmetry of the arch form. So this should be very simple for somebody who's trained. All they have to do is just pick the one that matches the shape of the arch without expanding or constricting, and then go on to the next step. Then it will auto-classify the occlusion. And so it attempts to find the mesial buccal cusp tip of upper first molars and the mesial buccal groove, or the buccal groove of the lower first molar. And then it comes up with a number. If that number is less than a absolute value of 1, so greater than -1, less than 1, it'll say that's a class 1 case, and it will give us class 1 simulations to choose from, where it's not trying to correct the bite in the back. It's just straightening the teeth, and we know we could extract, we could do IPR. It'll give you different choices, but it's going to give you simulations that are class 1 with no dental correction in the posterior teeth. Now, if we were to click class 2, it would give us class 2 simulations applying the value in this little box here to the simulation. So it'll give us class 2 elastics, it'll give us upper molar distalization, it'll give us a lot of different options, extractions, different ways we could treat the case to get the bite fixed in the back, and we'd be able to see how that played out orthodontically, how much advancement was involved. If it was a class 3 case, same thing. Okay, so it uses these values. If I don't like the way that it positioned these points, or I want those values changed, then I can come in here and manually adjust those points. Now, after you watch the seminar, you're going to receive an email, and you're going to get a link to go download a couple of PDFs. So let me show those to you real quick here. Go click back over to Medit link because I attached them. One of them is this little, I call it a scope of bite classification. And it's just reminding you where these values are coming from. And then it gives you the cutoff points. So it says, hey, for, if you know that there's a, let's pick one. Let's say that you know that there's a class 2 elastic plan with IPR and expansion, and you want to see that on your case, but you're not seeing it, it may be because your case has got values that don't fall within this range right here. You're out of that range and you're into a different range where it's giving you different simulations. So if you wanted to see that particular simulation, maybe one of your values on one side, it takes whatever side is greater. Maybe one of those values is greater than 3. So if you go and manually adjust it back to 2.8, then it's going to bring up a different set of simulations because that then falls within these cutoff, the scope of bite classification. So it's helpful to know a little bit about the programming so that you know where to adjust those in order to get the simulations that you want. And then it gives you some other information about, for example, when widths, when the skeletal anterior posterior, if you have the Ceph, when that changes the simulation. If you have a more severe class 3 case over here where the mandible is out in front of the maxilla, then it's going to automatically, depending on how severe that value is, it's going to automatically apply a certain amount of retroclination or lingual tipping back of the lower crowns and proclination or facial flaring of the upper crowns to compensate for that poor skeletal balance, for that discrepancy in the skeletal relationship. And same thing with class 2 cases. If you don't have the lateral Ceph, then it just assumes that all the cases are skeletal class 1. So this is a little bit of the complexity behind the programming. And there's a lot that you can do with this software, but it's designed to be very simple, to move through it quickly and to come up with some relevant simulations very quickly by somebody who's only trained to just click through the software and doesn't really understand much about it. And then you can understand more about the software and use it for more applications. The other thing you'll be able to download is this form that we use for doing an orthodontic evaluation that can be used in conjunction with this software, to do a little bit more evaluation of facial profile and facial type and gingival tissues, just to make sure that what you're deciding to do with the simulation would also benefit the patient's profile and just some helpful information. So those will be coming to you and you'll be able to download those. But coming back to our case, let's flip back over here. This case has been designated class 1. And so we're going to get class 1 simulations. So there was nothing to do on this tab. We'll just click on to the next one. Now it's going to produce the simulations. So a trained assistant or hygienist, if you're scanning every patient, could get to this point in about 3 or 4 minutes after scanning the patient. And then it takes it a minute or so to work up a variety of different applicable simulations. but this can be done while they're waiting for you to come into the operatory. And so if it was me, I would have my assistant or hygienist go ahead and click this over on the right side of the screen. It says occlusal surface view. I would click that and have this sitting there and probably even talk about it with the patient while I'm waiting for the doctor to come in. Now, assuming that I had a nice color, full color scan, you could start talking about discolored restorations. The patient will start asking questions, and they're going to see their crooked teeth sitting next to straight teeth. And so when you come in, the patient's going to ask you about some of the things that they're seeing, and you can look at it with them and very quickly go through and look at the conditions of their mouth and look at the restorations and the fractures and anything that you see that you want to talk about, rather than handing them a mouth mirror and trying to help them see what you're seeing when you look in their mouth. We have it all up here in color in 3D. And then you can also talk about, hey, have you ever thought about straightening your teeth? We have a little simulation here that shows straight teeth. And whether that patient came in for that or not, whether they're even interested right now or not, I promise you that if you have this type of conversation with all of your patients, the number of patients that you will do more comprehensive dentistry, that you'll do more of the kind of dentistry that really is gratifying and productive and that you enjoy. My AirPod just died, so let me put in my other one. There we go. Hopefully that's working. Yep, looks like we're, and you guys are hearing me again. All right, so at this point, you have a discussion with your patient about the benefits of ortho for this patient. And whether they do the ortho or not, whether you do it or you refer it out, this is an opportunity to really have those discussions that go beyond just, do I have a cavity? Do I need to replace a broken crown or what have you? So I find there's a lot of value in using this app and just taking a scan from just looking at a 3D scan, which I think you get a lot of value just from taking a 3D scan, as opposed to not taking the 3D scan. But then if you spend the extra 3 or 4 minutes to work up the case to this point, now you're having the kinds of discussions that leads to full mouth, comprehensive dentistry. Even if they can't afford to do everything right now, you can at least plan out, hey, it'd be nice to do the ortho. Eventually we like to do this and then this, and you have an idea of where you're going. And patients that you've had these types of discussions with, they may come in 5 years later, 10 years later, something different has happened in their life, and all of a sudden they're ready to do that thing that you showed them and that you talked about with them years before. So I find there's a lot of value in using this application on all of your patients. Okay, so once you get to this point, this particular patient, we want to talk about replacing a missing tooth up here. So let's look a little bit more closely at that. Sometimes the anatomy of a tooth will throw off the way that the computer interpreted a little bit. Like here you can see that it picked up a little bit of data on the back of that canine that kind of aligned it strangely. And I could do one of two things here. I could either click down here on this little tooth orientation tool, and I can change the way that the software is interpreting the rotation. So if I don't think it rotated that tooth properly and I think that mesial needs to come in a little bit, I can tell it it's positioned like that. And then when I go back over, it's going to have rotated that tooth a little bit differently. See, it affected the rotation of that tooth. So let me go show you with that canine. On the angulation, I click on that tooth and I say, you know what, actually the long axis of this tooth is more like this. And in fact, this little tapered incisor, it's pretty common when somebody has a congenitally missing lateral that the other one, if they have it, will be smaller in size and maybe a little bit tapered. And so here, when you align these teeth, you might end up with a large incisal embrasure. So we have to tip that crown a little bit more mesially. So if I come up in here and I change the long axis of this tooth, it's going to treat that tooth differently in the simulation. We'll do it to both of them. This is the one that got duplicated and put over here. So we'll do that to both of them. In fact, see, those incisal edges aren't perfectly lined up. So when I come in here and look at the way it aligned this tooth, I go, oh, it didn't find that incisal edge quite right. So just a little adjustment here will make it so that the simulation looks a little bit better. See how it closed up those diastemas there, aligned the front teeth a little bit better, fix that canine. Okay, but I can show my patient and have a conversation about the orthodontics involved. So I have a little tool here that shows an animation. And so I can show them how I want to push these two teeth back into the position where they came from to create space for an implant. And I have a bunch of different options because I can decide to restore this tooth that's a little bit too small into a larger size. I can open a little bit of space and advance those incisors and then restore this one a little bit bigger. Or I could just restore the one tooth to match the smaller one on the right side. When I look at the overjet, since she's a little bit class 3, you can see the problem from having those small upper laterals. We call that a Bolton tooth size discrepancy. So there's more tooth mass in the lower than there is in the upper because we have these small lateral incisors. So we could do this. We could restore those upper. So we only do one restoration up here and we leave that lateral alone. And then we'd have to do some IPR in the lower arch to pull those lower teeth back to reduce the tooth mass in the lower to coordinate with the smaller upper. So that would be one option. Another option would be to restore that bigger. So I can do that quite easily. Let's click back over to the tab where we identified the teeth. And all I have to do is go and click that I want to also restore this tooth, planned prosthesis on the 1-2, the other lateral. And I can quickly click back over to the simulations. It will recalculate real quick and show me a tooth that was taken out of the library to make that one wider. It didn't really orient that one very well. So let's change the orientation on that one a little bit. It's like it's oriented. I think that orientation right here is going to work better for us. And maybe even changing the inclination a little bit. So pushing that root a little bit more lingually. Let's see what that does. Looks a little bit better at the gum line, but I still have that little diastema right there. Let's go change that one more time. So I'm going to go to the angulation, click on that tooth, and just tell it that the long axis is a little bit more mesial so that it tips that crown a little bit more mesially in the simulation. Okay, now when you look at the overjet, it looks better because I have larger teeth there. You can see the rotation's off. So watch, I'll show you how the rotation tool works. There it is. You can see the rotation is off. So when I correct that, like that, that's going to look better in the simulation. There we go. So now the overjet looks better. I might still need a little bit of lower IPR, but I can now, if the patient is opposed to having lower IPR, I can restore both upper laterals. The other thing is this patient was concave in her profile. So if we go back and look at her face, we always want to treat to the face, and this patient could definitely use more lip support. She's definitely straight to concave through her face. So larger upper laterals might actually help her have a little bit more upper lip support. So I can actually see that overlaid onto her Ceph by clicking this little Ceph overlay tool. So I can see the amount of advancement coming with these size lateral incisors versus where we were at the start. So a little bit more lip support from a little bit larger teeth might be nice for her in the upper. I can also use this view to see how much I'm advancing the lowers. You know, is this going to be a strain on her tissue? Is there enough bone attachment there to be able to support this level of advancement of those lower incisors? I can also see this by looking at an overlay tool. Okay, so here's an overlay where I can see the start position and I can visualize the final position of those teeth. Okay, so I might need to limit that a little bit for this patient with some lower IPR to get it to coordinate with the upper. But what I like is I have a little bit of upper advancement when I use these two larger size lateral incisors. The other thing I have is a traffic light up here. You see it says green. That's telling me that the amount of advancement that I'm choosing for this simulation is within a predictable and safe range. If I get a yellow light here, I'm concerned that I'm either advancing or retracting those incisors too much, or especially a red, and I might want to think of a different way to treat the case. And there may be some times where we want to advance the lower incisors a lot. It really depends on the patient, how the inclination of their lower incisors to start, how healthy their gum tissue is, what their profile looks like. There's other factors that come in, but this light is a very good indication of, if I'm just looking for case selection, remember, and I've got here a yellow and 3 greens, and that yellow came from the fact that she was almost green, but was right on that border between yellow and green in the antero-posterior skeletal dimension. And so there's a little bit of a class 3, and I'm handling that with a little bit of lower IPR, or maybe making these upper restorations a little bit larger. But in case selection, these little traffic lights up here are very helpful. And even for those of us who are experienced, sometimes we just are paying so much attention to one area that we forget to look at another area. And so having these little traffic lights to make us realize that, oh, there's something going on here that's a little bit more complex, a little bit more out of the ordinary, a little bit further from ideal, and might introduce some complexity into the case. All right, so we've looked at 2 options already. We looked at restoring only one upper lateral and leaving the other one alone and doing more lower IPR to coordinate the arches. We've looked at restoring both upper laterals. If these central incisors were not good, as far as their color or shape, we could look at restoring all 4 upper incisors. But what about something really different? What if we considered, let me show you the ortho involved here again. What if I'm placing the implant myself, and what if I don't like placing implants in the aesthetic zone up there for that lateral, and I'd feel more comfortable placing it in the canine position? Would it even be a possibility to, instead of opening the space between the central and the lateral and the canine to place the lateral, could I use this canine as a substitution for that missing lateral? Let me show you how easy it is to look at a different option here. I can click back over. I'm going to clear this one. I'm no longer going to say that we're going to do a planned restoration here. I'm going to clear this planned restoration, and I'm going to renumber this tooth. I'm going to say, hey, this canine, let's call that the new lateral. So the software treats that as a lateral incisor. And then I'm going to tell it that I'm going to put a restoration at the canine position. And then we click back over the simulation, and it recalculates that and lets us quickly look at another option. You know, interestingly, this patient's canine is actually one of those that could potentially work as a lateral incisor. It didn't have a real high gum line to start. Let me show you the starting. Just kind of the shape of this particular canine. It doesn't have that real high gingival architecture, and it doesn't have a real thick emergence profile, and it actually wouldn't look too bad as a lateral incisor. We could do a little bit of bonding or reshaping of this and make this look like a lateral incisor, and then we could put the implant at that canine position. You know, so we could consider orthodontically a couple of different ways of treating the case. Now, if I was an orthodontist and I had a referring doctor, I would want my referring doctors to be using the software. One, because if they're scanning all their patients and doing simulations on everybody, there's going to be a lot more ortho referrals coming in, because the general dentist is going to see the value of the ortho treatment. And so is the patient. You know, I feel like as a general dentist, before I ever learned ortho, I never considered ortho. You know, if the patient didn't bring it up, I just wasn't considering the value of the alignment and how that would help the patient in so many ways. I mean, now that I do ortho, I can't even imagine doing restorative work without first aligning everything. And I just see so much value in avoiding restorations by aligning and just making things look nice and maintaining the original dentition. There's so many things I could talk for hours about the benefits of ortho. But sometimes as a GP, we don't see the benefit of the ortho, and neither does the patient. And so when we have a really easy simulation to work up, and then the doctor can visualize the value of the ortho, and so can the patient, there's a lot more referrals coming. And also, you know, maybe the doctor wants to treat the easy cases, the ones that come up all green, and then you want to take as a specialist all of the ones that come up with flags of yellow and red, and then you help them with the easy green cases to treat. There's so many ways that you could work it out. But now when you're working on a pre-restorative case and you're doing pre-restorative planning, you know, you guys can look at different options, and you can discuss different treatment options easily and come up with a plan for how you'd like to treat that case. The way that this case was treated, here's the final. You can see it was aligners only were used. There was a little bit of a struggle to create the space for the, getting the clinical crown space wasn't the big struggle, but it was getting the roots aligned properly. You can see there's the clinical crown space that was created. From a restorative standpoint, you probably have enough space there to put a small implant, but the oral surgeon that was working with it wanted more room, and the patient didn't want to have the braces placed on there, so they went ahead and did a beautiful no prep bonded Maryland bridge, and you can see that there was space created in the aligner setup to make the other lateral incisor a little bit bigger. The case came out real nice. But when you look at the ortho involved, it even helps you see where you might run into challenges with aligners only. And you can see the benefits of employing brackets at the start of the case or as auxiliaries during the case, or even to maybe fix something where there was some inadequacies or some weakness in the aligner treatment. And at the end of the case, the oral surgeon wants a little bit more room, or you need a little bit more room, and you're like, well, I could put brackets on here. But visualizing where that tooth was to start and how much things actually have to move. Let's go back to our other version, because it'd probably be more likely that we would keep that as a canine and restore this as the restoration. So let's look at that one more time. But when I'm working on more complicated cases where there's multiple missing teeth and I have lots of different options, I can distalize it bicuspid or I can mesialize it. And I'm looking at, maybe instead of using a full-size molar, I use a smaller bicuspid. When I can visualize the tooth, the case unraveling, and I can visualize my anchorage and the mechanics. Do I need to use a TAD? Can I use this tooth to push off that tooth? Kind of planning out my orthodontic treatment because I can see it quickly is really helpful. So I find this tool really valuable. I use it on every single case. You all know how nice it is to be able to see, a ClinCheck or a setup from an aligner company and visualize the treatment, but you don't get the treatment options. You don't get 4 or 5 different options that you can look at. And I want to know how I'm going to treat that case before I ever send it off to the aligner company. Now, if you're using progressive aligners, if you're interested in knowing about it, it's an excellent product. It's a really good aligner. I really like it. And if you find a simulation that you like, you can actually just in your submission instructions, just reference one of our simulation numbers. They have the protocols and they can just set the case up based on pre-written protocols. So in a case like this, I would say, hey, I want simulation 1.1, which is telling them it's just basically a level and a line. And then I would say, and I want to, restore the missing upper left 2, the upper left lateral. But other cases, there's a lot of different options to choose from. So let's assume this patient had all of the teeth and they were a little bit full and I wanted to do some expansion in IPR. I could look at what it would look like with expansion in IPR. So here's the expanded with IPR. I can compare that to simulation 1.1. And then when I come over here and look at the Ceph in position, I can go, hey, there's what simulation 1.1 does, gives this patient the lip support that they need. This one that has IPR and expansion, that is going to flatten that profile out. And, another case, you might want to look at one of the extraction options. And that's going to probably show even more, about the same retraction it looks like as doing the expansion, the IPR. Okay, but it allows me to quickly look at different options. So if there's a little bit of protrusion, a little bit too much advancement, I can look at different options so quickly without having to work with a technician to come up with all these different ways of treating the case. So I can decide what's going to be best for the patient's face, for their tissues, for the aesthetics I'm looking for the restorative work I want to do. And having this tool allows me to make all those decisions. So when I send it in for the aligners, I know what I want to do. If you're interested in knowing more about progressive aligners, you can reach out to us. We'll show you in a minute how to contact us. But that's how I'm using this software. It's in planning, it's in patient communication. There is a new iteration coming out of this software. It'll be coming out later this year. And in that software, you're going to see that there will be an aligner integration. And you'll be able to go right from this to aligner staging. It'll be auto staged, and there'll be 3D tooth controls, and you can actually then download individual STL stages and make your own aligners, or you can use our aligner manufacturer, but there'll be more integration at the end. We also have bracket output that gives you the correct torque and all the correct brackets to treat the case. We have treatment plans that go along with these simulations. That's what we do. We do education at Progressive Orthodontic Seminars. And so you're going to receive an email, and there's a link in that email that you can find out about free intro to ortho seminars that we have in different locations. You can also contact us. We invite you to come to any of our seminars the first day for free if you want to learn a little bit more, or anything we can do to support you in using this software. You know, we'd be happy to help you. So download the app, reach out to us if you'd like to. Come take one of our free courses. If you'd like to know more about progressive aligners or what's coming with the software, feel free to reach out to us. Any questions that you have, just email, and we will reach out and make sure that your questions get answered. So thank you so much for joining us. We're really grateful that you guys were willing to take the time to spend with us, and hope that you'll contact us and find out more, and that you'll find this useful. Thanks so much. We'll talk to you soon.